Hello and welcome to Culture Reset. I'm Caroline Kenyon, and this time our guest is someone who leads a national organisation with a mission to change the culture of the NHS. As there are more than 200 hospital trusts in England, that's no small task. So, hello Rosie Benneyworth. Would you like to introduce yourself and tell us a little bit about what you do?
Yes, thank you, Caroline. My name's Rosie Benneyworth. I am the interim chief executive of the Health Services Safety Investigations Body. HSSIB, as it's known, is a body that undertakes independent investigations across England to look at understanding the reasons why things go wrong. We cover all aspects of healthcare, and we undertake about 20 investigations a year, as well as providing an education programme to look at how do we support investigators at a local level to undertake really good quality investigations as well.
And you began your health service career as a GP, didn't you, in lovely Taunton in Somerset? And you've had leadership roles in Somerset Clinical Commissioning Group, in Health Innovation South West, and nationally in NICE, the National Institute for Health and Care Excellence, and the Care Quality Commission, or CQC. And now you're leading the Health Services Safety Investigations Body. I think you're someone who wants to be in a position to change things. Is that fair to say?
I think it's fair to say that. I've loved my career to date, and I was very privileged to be a GP. I think as a GP, I saw day in, day out, firstly, the amazing work that happens in primary care, but also I felt that there was quite a lot that needed to change, both in terms of how the system works together and the different parts of the system work together, and also how we make sure that we support people working in any service to be able to do the kind of most effective, high quality care that they can give, and we provide systems, processes, and environments to do that. So, throughout my career, although I have been in quite a lot of different organisations, there has been a golden thread of how do we really kind of improve quality and safety of care for people using services right across the services.
And presumably that grounding as a GP has given you a real sense of what it means to look after a patient directly, one-to-one, and that's always with you.
It is always with me, and as a GP, you're very privileged to spend that time with people, to build relationships with the patients that you look after. I was a GP for several years in the same practice, and I got to know my patients really well, and I got to know what was important to them, and what their goals were and what they wanted from healthcare services. And I also got to hear their frustrations about when things weren't working well. So that was really important. And I think the other thing that was very much important with my GP career was actually working as part of a multidisciplinary team, that culture we had within the organisation. I was lucky because I worked in a really lovely practice and had very supportive partners. We had a great team at the practice. And I think in terms of culture, how we build that support and that culture where people work together, where they work as a team, and we kind of value that, it's really important.
Yes, you said you could see you wanted to change things at a system level. And of course, now you're leading a national organisation which is caught up in the massive changes that are happening to NHS structures nationally and regionally. Where do you think your organisation is going to end up at the end of it all?
So we've recently seen Penny Dash's review into the patient safety landscape, and our organisation is likely to be moving to the Care Quality Commission in due course, and we will work with the Care Quality Commission to make sure that we are a really effective organisation going forward. I think the main thing for us is throughout all of these changes nationally, and we're seeing an awful lot of change. That the scale of changes is of a magnitude I certainly haven't seen in my career, with the scale of changes at integrated care boards, at NHS England, and I think what we need to make sure that during that period of time is that patient safety is not lost sight of. That we make sure that patient safety is the heart of those decisions. And I think there are real opportunities for us to look at how we manage safety in a different way during all of those changes. and kind of bake safety in to the changes that are happening and the changes that are outlined in the 10-year plan. So I'm looking forward to working with leaders in all of the different organisations to try and kind of influence that.
And do you have a heightened sense of alert, if you like, that there may be an impact on patient safety because of all the changes? I mean, we're all human. If we think our job's at risk or things around us are changing so much, we may lose our focus a little bit. Does that worry you?
Um, I am worried about how we maintain that focus at the moment. I think that there's a number of things that we see as our organisation. Firstly, that we know people on the front line are having to deal with enormous challenges and enormous pressures in their day-to-day work. There's huge demand on the NHS at the moment, a lot of pressures, a lot of financial pressures as well on the NHS, as well as the pressures around operational delivery. And people are having to manage that at the same time as the system around them is changing. And we know that any restructural change can lead to poor morale, can lead to people being distracted from what they need to deliver. And what we do know from all of our work on our investigations is that the care and the outcomes that people receive is inextricably linked to the health and well-being of the staff that are working across the services. So we need to really design those services that support the staff, that are going to enable better patient outcomes through making sure staff are valued, staff's health and well-being is considered at any point, at every point, and also thinking about how we design services and design the new ways of working with safety in the forefront, and that we set up systems that really kind of put the systems, process, and environments that people work in right at the centre of that thinking, so that we enable staff working in the services to deliver the best possible care for their patients.
And we'll talk in a minute about how you're helping that to happen. But in the meantime, your own work goes on, your investigations continue, the change won't impact on you immediately. But how is your team coping? How are they carrying on?
So they're an amazing team. I'm really lucky because I work with an amazing group of very passionate people who have come from lots of different parts of other industries. So I have team members from the military, from aviation, from nuclear, the nuclear industry, from legal backgrounds, and a fantastic mix of experts in safety. And my team have kind of hundreds of years of expertise around patient about safety and how it's managed, which is fantastic. So I think they're very keen to think about how we embed that learning into the NHS and how we learn from other safety critical industries to really kind of improve safety in the NHS. They have been going through a kind of emotional journey, I guess, as we've heard some of the announcements. But we are now back being focused on what we do and making sure that we deliver the best possible impact for care for people in this country and beyond. I should mention we also have an international network of patient safety organisations, and we want to share learning and share expertise right across the world and learn from other countries around patient safety, so that it doesn't take years for learning from another country to come to England. We want to make sure that that learning is shared rapidly and we can really kind of support the system to make the changes needed.
And you're role modelling that, looking after staff well-being. I've saw something on social media about you all doing something very healthy and active in the month of June. Do you want to mention what that is? Why are you doing it?
Oh yes, we did a fabulous challenge with 3 other organisations, and the challenge was how many kilometres can we run, walk, cycle, swim, or row in June? And we had a great app that we all used. There was a bit of healthy competition, and we went over kind of 3,500 kilometres, I think, in June as a team of 16, and I think we're solely virtual organisation. So the team are based actually from Scotland, Cornwall, and so we need to find ways of actually bringing ourselves together. We do meet from time to time in person, but actually, how do we generate that team spirit when we are a virtual team is really important. And I actually do believe that the health and well-being of the team is vitally important to make sure that we're effective in our work and we're productive and we're a happy team. And I think if people enjoy their work and feel well, then actually that's going to play a significant part on the impact that we can have.
Well done on all those kilometres. Exhausting, but sounds like fun. So coming back to your work then, could you give us some recent examples of what you've been investigating and what impact that's had?
Yeah, certainly. So recently we've done a lot of work around mental health inpatient units, and those investigations were directed by a former Secretary of State. And I think what came across with those investigations was, firstly, we still have a culture of blame in the NHS, and people still feel quite fearful about being blamed when things go wrong. And that was very much highlighted in those reports, but it's something we hear in all of the investigations that we do. And and often there's kind of barriers in the way that make people that don't help people do the right thing. And just to give you an example of that, we did some work looking at mental health inpatients and the staff's use of risk stratification tools. And all of the evidence and the national guidance says these tools shouldn't be used. And when we went out and looked at what was happening, we found all of the staff on the ground were using these tools. Now, a kind of a traditional NHS approach to that might be to say, naughty health professionals, why are you not following national guidance? And it's all the kind of their fault and they're doing the wrong thing. But when we explored it in more detail, it was fascinating because we found that actually the IT systems in use were forcing people to put in a risk stratification before they could move on to the next page. And also we found that the coronial system was also asking for these tools to be used. So you've automatically got these tensions across the system which are creating barriers to people being able to do the right thing and follow the national guidance in this case. So that's, I think, something we're trying to understand is, where are these barriers that get in the way of people being able to do best practice, follow best practice, do the right thing for patients, and how do we unblock those? Another thing we heard very loudly in that investigation was we're not very good still in the NHS, and we hear this quite a lot in a lot of our investigations about listening carefully to what patients are saying, and when patients raise concerns about their own health, how those are listened to and acted on. And I think we've still got a lot of kind of a big cultural change needed to think about how do we how do we work with patients and people as partners in their own healthcare? How do we really listen to what they're saying, and how do we really kind of support people in the decision making around their own health, and take their concerns seriously when they are raised? I could talk a lot about other examples if it would
Oh,
be
yes.
helpful.
We may do. We'll see how time goes. But when you do these investigations and you come back with a report and you make recommendations, don't you? What happens to those recommendations? How do you know that the organisation follows up?
Yeah, so we actually design the recommendations in collaboration with the organisations we're making them to, and that's considered best practice, because then they don't land as a surprise. And also, by doing that, we make sure that the recommendations are achievable and that they're going to be able to be delivered. Those organisations we make recommendations to have 3 months to respond to our recommendations, and we make recommendations to lots of national bodies, to the Department of Health and Social Care, NHS England, sometimes royal colleges, regulators, and sometimes a wider group of organisations as well. In our reports, we also have increasingly been putting in local learning and local prompts so that local organisations can understand what they can do to support improvements in patient safety. But what we've been doing over the last few months is looking at how we follow up the actions that people are taking from following the recommendations for a longer period of time. And sometimes those can take a year or two to start filtering out into the system. But we see on a very regular basis the positive impact that our recommendations are having on the system. A recent example is we investigated a very sad case, actually, of a child that died. And one of the contributing factors was that the child's parents didn't speak English and were sent information out via a hospital letter that was in English, and they couldn't understand that. It couldn't understand it, and as a result, the child came in for a scan and wasn't fasted for that scan. This child wasn't meant to eat or drink anything, and they couldn't understand the letter and understand that. So they were then lost to follow up, and the child's scan was delayed quite significantly. And sadly, the child ended up dying from cancer. And as a result of that, we made a recommendation to NHS England to look at actually how do we improve translation of letters out into the communities that need different languages and need more support in terms of understanding what the hospital letters say, because we know often there's translators in outpatient appointments themselves, but actually often the letters still go out in English. So I was delighted that NHS England have, as a result of that, put out a framework recently that supports, that works with providers to look at actually how do we address that issue. So that's just one example, but we've got multiple examples of where our work and our recommendations have led to change that filters out through the whole system.
That's great. That's such a great achievement, isn't it? Something you can really hang your hat on, if you like. You say, this is how it works. This is the kind of change it can make on a wider basis, not just in one organisation. Is there anything else that stands out for you? Because I know the organisation hasn't been going very long, really, has it? And you've been there for just 3 years. Are there any other highlights you'd like to mention?
Oh, there's so many highlights in terms of what we've looked at and what we've been doing. For example, we know that general practice, we know that patients often say they struggle with access in terms of general practice, and there has been a rapid expanse of GP digital triage tools that have been used, and we welcome that. I think patients need lots of different ways of accessing general practice, and for a lot of people, those tools are a really important way of accessing help and care. But what we found with those tools, and also with wider a lot of the work we do around digital systems, is that often people don't get the implementation support. They don't. The technology is great, but often people working in providers need more support to think about how they're going to use these tools. They also need, when people are involved in the procurement or the buying of these tools, they also need that support. They need clinicians involved in how to decide which product to buy. They need people who are using the services, so patients involved in that buying decision. But often that doesn't happen to the extent it needs to. So some of the work we've been doing is actually trying to support the system to think about how do you use these digital tools safely, and how do you make sure they're implemented safely so that everyone can use them as appropriate, and that the inequalities that might be present, so people who can't use digital tools, for example, aren't forgotten, and other options are available. So lots of work in that area. We've recently also published some work looking at discharge summaries from hospital. So when people have been in hospital, how do you make sure the right information is sent to the GP afterwards, or sent to the relevant health professional? And still we hear that the quality of information going from the hospital to the GP practice is poor, and often it can be quite delayed. And often it's because actually we haven't spent the time training the clinicians in hospital how to put together a good discharge summary. We haven't got the IT systems right. So this is the type of work we do to highlight where the areas of concern are. And then we look at how we can work with the system to ensure that those changes happen. So lots to do.
I think there'll always be lots to do. Is it simply a case of needing more money in the NHS, needing more staff, needing more resources, needing more digital technology? Does it come down to money?
I don't think so. I think there's some really interesting evidence showing the impact of poor care on financial situation and the financial situation of an organisation. There's an organisation called the OECD, who are an international organisation, and they've done some research that shows 13% of all healthcare spend is on safety failure in middle and high income countries like ours. So if you think about what 13% is of the whole healthcare budget, and if we manage to save even a fraction of that, and what that would mean in terms of investment into the services, that's enormous. They've also done some work that says about 17.5% of healthcare spend goes on diagnostic error and overdiagnosis, misdiagnosis, delayed diagnosis. And, you know, a small proportion of increase in funding can actually save a lot of money in terms of reducing that. We know there was a paper a few years ago now, but showed that 182,000 bed days a year, hospital bed days a year, were used for medication error. So on medication errors. So we have a lot of waste in the system because we're not getting good quality care. And my investigators day in, day out see good examples of where really productive care is really safe care, but they also see the opposite. A recent report we did looked at prison healthcare, and the number of ambulances that were called but then turned round before they actually got to the doors because they weren't needed was eye-watering. And the huge amount of ambulance wasted time that ambulances were spending responding to calls that didn't end up being required. So I believe the two go hand in hand, and I think we have to get to the decision-making thinking about the operational aspects, the financial aspects, and the safety and quality aspects, and those all have to go hand in hand. And there's a lot we can learn from other industries in terms of how they do that through effective management systems.
Hence your team with its very varied background in amongst your team members, which is really interesting to hear. We're going to have to bring this to a conclusion, sadly, Rosie, but before you go, I would like to put you on the spot and ask you to give one tip, which is what we do to all our guests. It's to do with resetting culture. That's the theme of the podcast, isn't it? So what would be your one tip that you would give either to leaders or the wider system or individual member of staff on improving culture?
So I think the one tip, I mean, I think there's lots, but I think the one tip is that it needs continual focus. It needs you can't just do culture once and it's done. It needs to be something that's part of every conversation, and culture changes on a day-to-day basis, and things can, change it quite rapidly. So you need to be really alert to that. If I could just say one other tip, if that's okay, because the other thing I think is as a leader and a manager in any organisation, it's really important to think about how you respond if someone comes and tells you they've done something wrong or something's gone wrong. I think that can actually define how comfortable people feel about speaking up, about how they will come and tell you about things that have gone wrong, or whether they'll hide it from you going forward. I think we need to support people. We need to understand that mistakes do happen, errors do happen, and how we support people in those moments afterwards and weeks afterwards is really vital. And we need to move away from this culture of blame and really think about how do we generate a culture of learning.
That's a whole other podcast, isn't it? I'll have to invite you back, Rosie. But thank you so much. That's been a fascinating listen, and good luck to you with whatever comes next for the Health Services Safety Investigations Body. And thank you for
Thank you.
listening. Oh, thank you, Rosie. And thank you for listening to this episode of Culture Reset. Next time, I'll be back with my usual co-host, Juliet Kumar, with another great guest with experiences to share about improving culture. Until then, goodbye for now, and please keep listening.